Your doctor just called. Routine screening. Come on in. Nothing to worry about. Just checking things like we do every year. And you'll go. Because that's what responsible people do. That's what you've always been told. Stay on top of it. Catch things early. Be proactive. But what if some of those routine tests, the ones that feel like good medicine, the ones that feel responsible, are actually more likely to hurt you than to help you after the age of 70? I know how that sounds. Stay with me. Because today we're diving into something that the medical research has been quietly showing for years, but that almost never makes it into the conversations most people have with their doctors. There are 5 routine medical checkups that published guidelines and peer-reviewed research suggest you should seriously question after age 70. Not because medicine is bad. Medicine saves lives every day, but because the risk-benefit math on these specific tests shifts dramatically as we age, and most people have no idea. By the end of this video, you'll have 4 specific questions you can bring to your next appointment that will completely change how you advocate for yourself. Let's get into it. The screening math, why everything changes at 70. Before we get to the 5 tests, you need to understand one concept. I call it the screening math, and it flips after 70. When you're 50, screening makes perfect sense. You find a small cancer, you treat it early. You have 30 or 40 years of healthy life ahead of you. The math works. The benefit is clear. But after 70, 3 things change simultaneously. And they change everything. First, many cancers and abnormalities in older bodies grow so slowly they will never cause symptoms in your remaining lifetime. You would die with them, not from them. Finding them doesn't save you. It just starts a clock ticking on fear, anxiety, and treatment. Second, the body becomes more fragile with age. Biopsies, surgeries, anesthesia, and recovery all carry meaningfully higher risk at 78 than they did at 55. Third, and this is the one that changes the game, the cascade effect. One abnormal finding triggers a follow-up test. That follow-up triggers a biopsy. The biopsy triggers a surgery. The surgery triggers a complication. And suddenly, someone who walked into a clinic feeling perfectly fine is fighting to recover, not from a disease, but from the process of looking for one. Researchers and geriatric health specialists have been writing about this for decades. The system is designed to find problems and treat them. What it's not always designed to do is ask, will this treatment actually make this specific person's life better? Now, the 5 tests. Test number 1, routine colonoscopy after age 75. Let me tell you about Eleanor. Eleanor was 78 years old, lived outside of St. Louis, Missouri. Sharp, active, walked 2 miles every single morning. She'd had clean colonoscopies in the past. No symptoms, no family history, no concerns at all. But at her annual visit, her doctor noted it had been 6 years since her last one. Time for a repeat. Eleanor didn't want to. She felt fine. But she trusted the process, so she went. The bowel prep, the preparation you do the night before, nearly put her in the hospital before the procedure even happened. Severe dehydration. Her potassium levels dropped dangerously low. Her heart began beating irregularly. She ended up in the emergency room. The colonoscopy never happened. And here's what makes Eleanor's story so painful. It didn't have to go that way. The United States Preventive Services Task Force, the official body that sets screening guidelines in this country, recommends against routine colonoscopy screening for average-risk adults after age 75. The data is clear. After that threshold, the risks begin to meaningfully outweigh the likely benefit. Bowel perforation occurs in roughly 1 in every 500 procedures. In a healthy younger adult, that's a serious but manageable complication. In a fragile 78-year-old, it can mean emergency surgery, a colostomy bag, weeks in the hospital, and sometimes it is fatal. What to ask your doctor? If you're over 75, have no symptoms, no family history, and previous clean results, ask whether a simple annual stool-based test might be a safer alternative. No sedation, no prep, no perforation risk. Test number 2, aggressive cancer screening in your late 70s and 80s. This one is going to feel controversial, so let's be precise. This is not about never screening for cancer. This is about what happens when aggressive cancer screening in your late 70s and 80s leads to overdiagnosis, And overdiagnosis leads to overtreatment of cancers that were never going to hurt anyone. Studies published in major medical journals have shown that a significant percentage of breast cancers detected by mammography in women over 70 are what oncologists call indolent, slow-growing, unlikely to ever cause symptoms or death. They were always there, they would have stayed quiet forever. But the moment the word cancer appears on a radiology report, the system activates. Biopsy, surgery, radiation, sometimes chemotherapy, each with side effects that can devastate an older body. Immune compromise, fatigue, wound complications, cognitive effects from repeated anesthesia. For prostate cancer, the problem is arguably even clearer. PSA levels are commonly elevated in older men, and most of the time mean nothing dangerous. But an elevated PSA triggers a biopsy. Biopsies carry a real infection risk, sometimes requiring hospitalization. And if a slow-growing cancer is found which happens often, a man may be pushed towards surgery or radiation that leaves him incontinent and impotent for the rest of his life. For a cancer that statistically would never have bothered him. Meet Walter, 81, retired school principal from rural Georgia. His PSA came back slightly elevated at a routine visit. Biopsy found a low-grade prostate cancer. Surgery was recommended. Walter trusted the process and went through with it. 6 months later, he told his family, "I wish I'd never taken that test." His cancer was almost certainly the kind a man his age would have died with, not from. The question to bring to your doctor: if this screening finds something, what would we actually do about it? And would that treatment improve my quality of life or just extend my anxiety? That one question will tell you everything. Test number 3, routine. Cardiac stress testing without symptoms. This is the one that causes the most concern because it sounds the most reasonable. Your doctor says, let's just check how your heart is doing. You get on a treadmill, or they give you a medication that simulates exercise. Sounds thorough, sounds responsible. Here's the hidden problem: false positives. Cardiac stress tests in people without symptoms have a false positive rate that can approach 40% in certain populations. That means nearly half the time the test raises an alarm when nothing is actually wrong. But that false alarm doesn't sit quietly in a chart. It triggers a cardiac catheterization, where a tube is threaded through your wrist or groin into your heart. That procedure carries real risks: bleeding, blood vessel damage, and in rare cases, a heart attack or stroke during the procedure itself. And if the catheterization finds a partial blockage, which is extremely common in anyone over 70, just as knee cartilage wear is common in anyone over 60, a stent may be placed. Here's what multiple large clinical trials have found. For patients with stable heart disease and no symptoms, stents do not reduce heart attacks or extend life compared to medication management alone. Follow the chain. You felt fine. You got a routine stress test. The test triggered a catheterization. The catheterization led to a stent. Now you're on blood thinners with serious bleeding risks for the rest of your life. And statistically, you are no better off than if you'd taken your medication and gone for a walk. The bottom line: if you have no chest pain, no shortness of breath, no symptoms, a routine stress test is going looking for trouble. And in medicine, when you go looking for trouble in a 75-year-old body, you will almost always find something. The question is whether finding it actually helps you. Test number 4. Routine. Bone density scans right away. Let's be clear. Osteoporosis is real. Falls are devastating. This is not about dismissing that. But here's where the logic quietly breaks down. A bone density scan tells you your bone density is low. A medication is prescribed, typically from the bisphosphonate family. You take it faithfully for years. And then something deeply ironic can happen. Long-term use of these medications has been associated with a specific type of fracture called an atypical femur fracture, the very kind of break the medication was prescribed to prevent. These drugs have also been linked to severe jawbone deterioration, a painful condition that is difficult to treat and can seriously affect daily life. And meanwhile, the single most effective intervention for preventing fractures in older adults isn't a pill at all. It's fall prevention, Lance exercises, removing throw rugs, installing grab bars in the shower, getting vision checked annually. Reviewing which medications cause dizziness or lightheadedness. These practical, cost-free, zero-side effect steps reduce fracture risk more powerfully than any medication currently available. If you're already on bone medication, don't stop it without a conversation with your doctor. That's not the message here. If a routine scan is being suggested and you've never broken a bone and have no significant risk factors, it's worth asking whether a structured fall prevention program might be the smarter first investment. Test number 5. Routine carotid artery ultrasound screening. This is the one that sounds the most logical and carries some of the most serious risks. An ultrasound probe on your neck checks for blockages in the arteries supplying blood to your brain. A 60 or 70% blockage is found. That sounds alarming. Naturally, the next step is referral to a vascular surgeon. Now you're facing a carotid endarterectomy, a surgery to clean out that blockage. Here's what the research shows. If you have no symptoms, no mini strokes, no sudden vision loss, no episodes of weakness or confusion, the surgery itself carries a 2 to 3% risk of causing the very stroke it's trying to prevent. In older adults, that risk climbs higher. The U.S. Preventive Services Task Force specifically recommends against routine carotid artery screening in adults without symptoms. Their conclusion: in people who feel fine, the harms of surgery, including stroke, heart attack, and nerve damage, outweigh the potential benefits. This is Raymond's story. Raymond was 79. He lived independently in Delaware, drove himself to appointments, cooked his own meals. He went in for a routine screening ultrasound. A significant blockage was found. Surgery was recommended. Raymond walked into that operating room cracking jokes with his daughter in the pre-op waiting room. He came out with a stroke that left him unable to speak clearly for the rest of his life. The blockage had been there for years, likely silent for decades. But the surgery to remove it triggered the exact catastrophe everyone feared. His daughter later said, "He was healthy until the day they tried to make him healthier." The 4 questions, your toolkit for every appointment, write these down. Save them in your phone. Bring them to every doctor's visit from this point forward. Question 1. What exactly will this test look for? And what happens if something is found? Question 2. If something is found, what would the treatment be? And what are the real risks of that treatment at my age? Question 3. What happens if I don't get this test? What's the actual risk of doing nothing? Question 4. Is there a less invasive alternative that gives useful information without the same level of risk? Any physician who genuinely has your best interest at heart will welcome every single one of these questions. They'll lean forward. They'll engage. They'll be glad you asked. If a doctor gets defensive or dismissive, that reaction is itself important information about the quality of care you're receiving. One more time, let's be crystal clear. This is not about avoiding medical care. This is not about ignoring symptoms. Blood in your stool? Get a colonoscopy. Chest pain? Get evaluated immediately. You've had a mini stroke? Get that carotid artery checked without delay. Symptoms change everything. Every word of this video has been about a completely different situation. This is about the routine screening, the let's just check, when you feel perfectly fine. That kind of screening has a fundamentally different risk-benefit calculation after 70. And the research has been saying so for years. You have the right to ask questions. You have the right to understand the risks on both sides. You have the right to say not right now. And you have the right to say no, your body, your choice, your life. If this video gave you something useful, hit that like button and share it with someone you love who's navigating healthcare after 70. Subscribe for more conversations like this every week. Ones that give you the full picture, not just the comfortable version. And leave a comment below. Have you ever had a routine screening that led to more problems than it solved? Your story might be exactly what helped someone else make a better decision. I'll see you in the next one.